Now let's take a look at aortic dissection. So now we've completed peripheral vascular disease. We walked through venous insufficiency, and we also talked about peripheral arterial disease. Let's take a look at aortic dissection. What does this mean to you? It means that literally the aorta. Now, what I'd like for you to do is come out of the left ventricle, come out of the aortic root, come through the ascending aorta, the arch, and then thoracic. Stop there, please. Okay? Why? Because clinically speaking, there are two major dissections. These are called Stanfords, and it's important that you know the exact location of that aortic dissection. I had you stop at thoracic aorta. Are you picturing this? And the two major components will be the ascending part of the aorta or the thoracic aorta. Are you picturing it? Good. These were the two places where if aortic dissection was to take place, you would then call it either Stanford type A for ascending aorta, or Stanford type B, as in thoracic aorta, distal aortic dissection. Is that clear? Now, what are some of the predisposing factors of developing an aortic dissection? Well, let's take a look. It's an emergency. Stabbing back pain, because there's an actual dissection. You cut right through, not you, but the pressure, shall we say, dissected right through the aorta. During the dissection, the line of the aorta, the intima, tears. So now, the intimatemost is the innermost. The middle portion is the media, M and M. Those are the two layers that I want you to pay attention to specifically. Those are going to tear, and when they do so, this is not a good situation. You might have blood which then does what? Well, it'll rob the blood from the subclavian. It'll then lead the blood perhaps back proximally into the pericardial cavity. It may result in cardiac tamponade, sudden rush of blood. Wow, isn't this cardiac tamponade? Of course it is. Is this an emergency? Yes, it is. What do you want to do? Remove. Surgery is what you're thinking. Risk factors include, well, they should make sense to you. What if there's too much blood pressure? There's excessive hypertension. Over a period of time, it might cause complete rupture and dissection. Marfan. You pay attention to F in Marfan. Who's your patient with Marfan? Think about Abraham Lincoln as an example of a typical patient Marfan. Tall, lanky. You have your fingers that are quite elongated, like a spider, arachnodactyly. Maybe there is a visual disturbance because the F in Marfan is coding for F, the fibrillin gene, with chromosome F15, which is then coding for what part of your tissue? Elastin. So this elastic tissue is not present. Suspensory ligaments that places or holds the lens in place, not there. Dislocation, subluxation of the lens. So there's your patient, Marfan. Go into the aorta. What happens? Well, either the thoracic aorta or the ascending portion in which, the elastic tissue is not present. What happens? You are now prone to a dissection. But before that, what then happens? A cystic medial necrosis. I mean to say that the media, which is what portion of the blood vessel, the middle portion of the aorta specifically, will undergo necrosis in which you form a cyst-like cavity. If that's not properly identified and corrected, you're worried about, dissection. Which one's which again? Stanford type A is an ascending. Stanford type B would be the thoracic aorta, the dissections. Atherosclerosis, a risk factor. Ehlers-Danlos. What do you know about this? Deficiency of collagen, depending as to which type. And then coarctation of aorta. How much pressure is there in coarctation of aorta? Well, Dr. White, you didn't tell me where. I understand that. If it's distal, you don't have enough pressure. But proximally, what have you done? You have introduced a resistor in a series. What happens to the pressure proximal to the resistor? Increase. That's where the problem is. Too much pressure there. Are you prone to dissection? Yes, you are.